infection. TB, the question will usually be about treatment. You will have a chest x-ray, so make yourself familiar with a chest x-ray. Go to Google, type uh, TB infection. You'll find tons of those images. You may see a miliary TB, bilaterals. You may see a cavity on the apex. Like, there's tons of those, but very likely you will have the one with a cavity. So look for the apex for the cavity. The treatment, it depends on, does the patient has HIV positive or negative. If he's positive, then the treatment will be extended, longer treatment. The duration will be longer. If it's HIV negative, then you need to start with 4 anti-TB medications for 2 months, then 2 medications for 6 months. 4 for 2, then 2 for 6. If it's HIV positive, you extend those 6 months to 9 months. If the patient has a latent TB, means acid fast bacilli in the BBD test is positive, but the patient has no symptoms, chest X-ray is clear, then you need to treat them with prophylaxis with anti-TB medication for 2 medications, preferred isoniazides and rifampin for 6 months, 9 months for again HIV positive patients. Uh, this is the most common questions about TB, so you need to make sure the image and understand the chest X-ray with the duration of treatment. The next, they may ask you about a pleural fluid that was positive for or suspicious for TB. Then you need to do acid fast bacilli cultures, and if you're still suspicious, you can do deaminase, adenosine deaminase testing. That will increase your sensitivity for the test. The other question you may face on the board is a patient with red eye, and that's, you just need to again leptospirosis. Just check on Google, check many causes of leptospirosis. You're gonna see the eyes red with conjunctival redness, and it's called suffusion. It's kind of hemorrhage under the bulbar conjunctiva. This is the suffusion. This is suffusion. And it's just spot diagnosis. Sometimes they have the symptoms of just like malaria, fever, elevated liver enzymes, hemolysis, dark urine. Again, usually these questions would be only about diagnosis. Fever of unknown origin, another questions you may see on the board. To classify this question, the patient has to have a fever of 38.3 or 109 Fahrenheit for at least 3 weeks, and you have to do if the patient comes to an outpatient clinic at least twice for workup and nothing came back positive, or inpatient for at least for 3 days. To classify it, there is a classic causes, which is maybe infection, bacterial, viral, UTI, complicated urinary tract infection, maybe an abscess or collection or hidden infection somewhere, either viral or bacterial. The other option is to look at it if the patient has a neutropenia. If it's neutropenia, then you start thinking about pseudomonas infection, strong gram-negative infections, or fungal infections, candida. Also, still on the options and differential diagnosis will be uh, TB, PE, malignancies, health associated infection. Patient was in the hospital or in a facility in the previous 3 months. Then you start thinking more about pseudomonal and gram negative infection, PE, thrombophlebitis at the site of a peripheral IV line or a PIC line or a central line, a device if he just had a device recently or a procedure. HIV patients, those are different category. You think more about opportunistic infections, Mycobacterium avium, atypical Mycobacterium, Cryptococcus, and other opportunistic infections. A drug associated in fever or induced fever, this is also should be in the differential diagnosis, especially if you see anticonvulsant medication that's recently added, especially in the previous couple of days up to weeks. Then and usually this is with an diagnosis of exclusion. Everything came back negative. Then you think about this medication, you stop these medications, and the clue and the key there will be an anticonvulsant, maybe valproic acid, dipicot, carbamazepine, or it will be a beta lactam antibiotic, or the other options maybe sulfa medication, alpurinol. Those are the common ones. Also, in the drug fever, they may associate it with rash, urticaria, mucus ulcers, eosinophilia like Dress syndrome. Of course, there is also the Steven Johnson and 10 syndrome. You need to understand and know those infections. Transplant. Transplant medicine, and after patients who knows to have a solid organ or a stem cell transplant, then he came back with a fever or signs of infection. They are susceptible for all kind of infections, but on the test they want you to understand couple of them. Most common one on the test is uh, BK virus, GC virus, and those has to be associated with CMV. So the patient has to have an active BK virus, multifocal leukoencephalopathy with the GC virus. Those patients present with kind of encephalitis, altered mental status, maybe focal neurological deficits. You do brain CT scan, it's negative. Then this is more likely GC virus. If the patient comes with urinary tract problems like ureter strictures, kidney transplant with acute rejections with AKI, hematuria, tender transplanted organ, then you think about BK. And I try to connect those viruses. You can use your own tricks, but one of them is BKK stands for me. I think about the kidney and kidney ureter problems. GC, C encephalopathy. So I think more about encephalopathy and multifocal progressive leukoencephalopathy infection. If the patient has a hematologic or stem cell transplantation and he got infected with BK or BK virus activated, he will come with hemorrhagic cystitis. So that's the clue, hemorrhagic cystitis. And recently stem cell transplant, then those patients to be symptomatic need to have CMV active infection. That's why we use in the prophylaxis anti-CMV for at least 4 weeks and sometimes up to 3 months with ganciclovir. And we use ganciclovir for transplanted patients with solid organ because one of the most strong side effects for ganciclovir is myelosuppression. And you don't want to use bone marrow suppression for a patient with stem cell transplant or hematologic transplant or hematologic disease. So we use ganciclovir as a prophylaxis. For treatment, if the patient has a BK virus, if a patient has CMV virus, you need to improve their immunity. So you have to stop the immunosuppressants. And if you think about CMV, you need to treat CMV. If the patient CMV antibody is positive or PCR positive, you need to treat CMV to improve his immunity and to treat his BK virus, which is associated with. Also, AB virus can be associated with CMV, and EB virus more you will have with lymphoproliferative lymphadenopathy all over, hepatosplenomegaly. Most of the time, if a transplanted patient came back with lymphadenopathy, you have to think about EBV virus. Acyclovir is used only for prophylaxis for CMV, and we don't use acyclovir for treatment because of high side effect and difficult to use. You have to give it like 5 times a day, so it's not a good option. For treatment toxoplasmosis, we use sulfadiazine pyrimethamine. For PCP treatment, we use IV clindamycin or pentamidine or primaquine. For GC virus, stop the immunosuppressant and improve the immunity supportive treatments. So For prophylaxis, again, you need to know what's the prophylaxis, what's the treatment, and where to focus on. If the patient has post-transplant neutropenia, you need to give them prophylaxis antifungus, anti-PCP, and anti-toxoplasmosis. That means voriconazole, trimethoprim sulfamethoxazole. Trimethoprim sulfamethoxazole will cover both toxoplasmosis and PCP, pneumocystic cardiac. The other one you're gonna see on the test is C. diff. C. diff patients comes with a diarrhea, usually healthcare associated or was on antibiotic in the previous 3 months. Then you start thinking, okay, PCR test came back positive. The question will be about treatment. If you need to talk about treatment or give them treatment, you need to ask, is this is a mild or severe disease? Severe disease means they are very sick, septic, fever, and organ damage with AKI, liver injury, hypertension, acidosis, lactic acid. Then you need to start treating them not just oral vancomycin or fluoroxamycin. Then you have to add IV flagyl or IV metronidazole. This is the difference between severe and non-severe. If it's severe, you need to add IV flagyl. If it's not severe, mild to moderate disease with no end organ damage, then you can start for the first attack with vancomycin or fluoroxamycin. First attack. Second attack will be also you give again oral vancomycin or fidaxomicin. Third attack, it's the time you need to give or to do a transplant, which is microfecal transplant. Of course, you need to understand also when to do surgical intervention when there is toxic megacolon. That's the answer for the surgeons. Of course, when if the patient has severe attack or severe recurrent, the vancomycin treatment is not just like 7 or 10 days. It will be extended for long duration and slowly tapered. The other one on those infections are the catheter associated infections. Those patients with a central line, PIC line, port line, and they come back with a fever. Blood culture is positive. What you have to do. So do I need to remove the line? Those are the questions. What kind of the antibiotics, and if you need to remove the line. Yes, you remove the line if there is a signs of infection around the line, like redness, tenderness, pus, abscess, pocket of abscess. Then you need to remove the line. If the patient is severely sick, sepsis, infection, multi-organ failure, then yes, you need to remove this line. If it's a strong vicious infection, Pseudomonas or Staphylococcus aureus, MRSA, you don't need to remove the line if he's not that sick, if he's active, um, no signs of line infection, um, bacteremia treated or culture came back negative in less than 72 hours, the fever is not extended more than 72 hours, then you don't need to remove the line. MSSA, you don't need to remove the line if the patient is not sick. Uh, Treatment, after you remove the line for the severe sick one, you need to give anti-staphylococcus aureus, anti-pseudomonal for the patient at risk for pseudomonal infection, and narrow the spectrum once you have the culture and sensitivity. What if the patient has persistent fever more than 72 hours? Then you need to do a workup for metastatic infection, thrombotic infections. They may have multiseptic pulmonary infections. They may have thrombophlebitis, infective endocarditis. You have to do transthoracic echo and prefer to go for do TEE. If transthoracic echo is negative, it's not enough, so you have to do a transesophageal echo. A treatment for our duration of treatment up to 2 weeks if the patient's cleared with infection, culture came back negative, symptoms improved in less than 72 hours. So 2 weeks is enough. But if the fever persistent and infections and the patient was very sick, or there is a vegetation or infective endocarditis or suspected for metastatic infection, then you have to extend the duration for 4 to 6 weeks.